Hello, everyone. My name is Anne. I'm one of the PGY2s, and I will be presenting the afternoon report. We can go ahead. So the chief complaint for today is going to be shortness of breath. So this is an 86-year-old female with history of hypertension, HFpEF, diabetes, CKD stage 3, who presents with acute and chronic shortness of breath for the last 3 days. At baseline, she has dyspnea on exertion, but she was able to walk inside her house with a walker. However, for the last 3 days, her shortness of breath was worsened and now is present even at rest. She was also complaining of worse dyspnea while lying flat. The review of system was positive for bilateral leg swelling and also positive for shortness of breath. The rest was pretty much unremarkable. Her past medical history was significant for hypertension, HFpEF with an EF of 70%, type 2 diabetes, well controlled, less A1C 6.3, and CKD stage 3. Past surgical history, remarkable for cataracts, and social history. She was a former smoker. She stopped smoking in 1993 after 27 years of smoking half a pack per day. No alcohols or drugs. She lives by herself and has a home health aide 4 hours per day, 7 days per week. She ambulates with a walker at home and uses a wheelchair to go out. She has lived in New York City all her life, and there's no allergies, and her meds were amlodipine, toprol, torsemide, Trajenta, and insulin. Her vital signs on arrival were these ones, like blood pressure 117/59, pulse was 75, afebrile, respiration 21, and SpO2 96 on room air. She was a little bit overweight. Her BMI was 26.29. The physical exam, as recorded per admitting team, was just positive for decreased breath sounds on the right base and 1+ lower extremity edema bilaterally.
Okay, guys, so we have some information. Does anyone have questions? Let's pretend you are seeing this patient. Anything that you would want to ask her?
Any recent medications started?
No.
When was her last echo?
1 year ago. No fever, no cough, and no sick contacts.
I also have a question. Any changes in the dosing of her medications?
No.
Eduardo is asking med compliance, drinking more water.
She was compliant with medications and no chest pain either. No, no drug use.
Any sick contacts or recent travel?
No.
What's her living situation?
She lives by herself. She has a home attendant.
Anyone else? So Tom, I don't know if you can see, but Tom is asking about the shortness of breath, if it's changed, if it's worsening, if it's a slow progression.
So at baseline, she had some mild shortness of breath, but it's been worse for the past 3 days.
And then Eduardo is asking if it does feel similar to previous episodes of the compensated.
It feels similar. The only thing is that this time is even worse when she's lying flat.
Weight loss?
No, no weight loss, no changes in diet.
A question I have is actually about the physical exam. You're mentioning edema. Is that new? Is that worse? Is that her baseline?
It seems like it's her baseline.
Okay. And then Bruno is asking if she smoked, and Mary is asking if she has history of DVT-PE.
No history of DVT-PE, and she's a former smoker. She smoked for 30 years. No recent hospitalizations, no dysuria, no cough.
Okay, so we have some more information. Who wants to summarize the case? And as we always do during the afternoon report, we want to do something called problem representation. So trying to put together the most important information in order to create in our mind a possible differential diagnosis. I don't really see your names, guys, because I'm sharing my screen. Does anyone want to tell me a little bit what they would summarize the case? And I apologize, but they reconstructed the entire hospital right now, I guess. Noble, do you want to try and
Yeah, sure.
do a problem representation?
Yeah, so 86-year-old female with previous history of hypertension, HFpEF, 70%, CKD, who has a history of chronic dyspnea before on exertion, now complaining now at rest as well. On physical exam, so patient had bilateral leg swelling and also some decreased breath sound bilaterally, and 1+ lower extremity edema bilaterally. But there's no significant history of like no chest pain, fever, no recent travel. So a little bit unclear what's going on. And no dysuria cough, so no infectious thing.
Absolutely. And then usually we want to kind of categorize the patients in, young patients, middle-aged, elderly. So she will be an elderly female, but definitely you put together a lot of information. I think it's important in this case to also mention her past medical history because she has so many risk factors for a lot of diseases. And the fact that she hasn't really changed her medications, looks like she's taking all of them. Okay. So I think what we could do now is trying to think about what you guys would do and how you would guys approach this patient, okay? So we are saying that she's elderly, she's female, she has many past medical history with cardiovascular diabetes, CKD, and she's taking many meds, but she's compliant. And then she has this acute worsening of her shortness of breath. So her chief complaint is basically dyspnea. And I think in her case, it's important that we notice that she's coming with some signs of fluid overload, okay? Because she's saying that she has orthopnea, which is kind of new. And then she has this lower extremity edema, which we don't really know. Looks like it's a baseline, we're not 100% sure. But also, we have some physical exam findings of right lower lung field with some, decreased breath sounds, but no crackles, okay? How would you guys think in your mind about patient that's coming with dyspnea and maybe some fluid overload? How would you approach it? What would be your differential, and what would you think if you were in the ED?
Hypertensive emergency, one option.
Okay, so that's a good point. So we always want to make sure that we rule out the most, serious situations. The only thing for her blood pressure looks fine, but we don't know if maybe she was home and she had a very high blood pressure and now she's coming with some edema. What type of edema would the hypertensive emergency cause in her case?
It'd be more bilateral though, yeah.
Exactly. So it would cause like maybe a flash pulmonary edema, something like that. Nadim is saying heart failure exacerbation, and then chest x-ray. Yeah, so we're gonna go to the workup. So I think for me, an easy way to divide the dyspnea is basically think about primary causes and secondary causes, where primary causes are usually from either the cardiovascular system or the lungs. And then going from there, trying to rule out, the things that can kill the patient. So from cardiovascular, what type of dyspnea can kill the patient? And we really need to think about it. definitely hypertensive emergency is something that we define a differential. Okay, PE, ACS, MI, perfect. So PE will be both lungs and cardiovascular, MI, ACS, acute decompensated heart failure, definitely that's something else that we need to think of. For lungs, we will put also PE. Anything else that's acute that we need to think of for patients with acute dyspnea. Severe pneumonia, okay. Malignancy, definitely, it wouldn't be, usually something that we have to rule out right away unless there's complication of the malignancy. Pneumothorax tamponade, perfect. So you're saying all of the right things. What are secondary causes? Oh, I don't know what I did. What are secondary causes of dyspnea that are not really cardiovascular or lungs? Anemia, cirrhosis, perfect. Definitely anemia, cirrhosis, anxiety, absolutely. We have to think about that. Autoimmune, yes, so yes, but autoimmune will still, kind of affect the lungs, right? So that's kind of connected, but definitely another type of etiology. Another thing that since dyspnea is such a big differential diagnosis, we have to kind of add other information, right? So I think the fluid overload is a very important thing that we always need to find out about the patient, because if we have suspicious of fluid overload, new edema, worsening edema, let's think of other sources of edema. For example, facial edema that we might think anasarca, or abdominal GERD, we might think of ascites, or orthopnea. Orthopnea is a classical sign that there's fluid overload. So we're going to think of cardiac origin, hepatic origin, or of course, kidney. So possible nephrogenic symptoms. So that's something that we always have to kind of rule out when we see a patient with new dyspnea. And then of course the time course. So it's different if it's super acute, like this patient looks like all of a sudden she has a worsening shortness of breath, versus someone that has a chronic, let me just take this off. Someone that has a chronic, presentation. And then we also look for a third thing that some of you asked for, which is fever. Fever is very important because then we're gonna move our, our thinking towards possible like pneumonia or pericarditis, myocarditis, any type of infection coming from the heart. So now let's think about our patient and what type of workup would you want to do? I think Debbie had said chest X-ray earlier. That's perfect. We want to know what's happening in the lungs. What else would you guys get in specifically our patient right now? Okay, so BMP, procal CBC. So let's start from, okay, TTE, absolutely, troponin. Why do we want to get troponin, Nadim? She doesn't have chest pain. I want to know.
In elderly patients, female patients, they can have an atypical presentation of MI. So you want to have a low threshold to do a drug.
Absolutely, perfect. And then BNP, absolutely want to see if she has any exacerbation. Procalcitonin, why would we want to get procalcitonin, Richard?
It just gives you kind of a hint if this is a bacterial pneumonia. It wouldn't really help you if it was viral, but it's just something that could be useful since it's just right lower lobe and so focal, it might be helpful.
Okay, so definitely I agree that there's something focal happening. Just for physical exam helps us. She does not have bilateral crackle. She has decreased right lower field. We don't really know if it's the low, but like there's something happening in the lungs. The procalcitonin is not sometimes that specific that tells us what's going on. So always remember that the diagnosis of pneumonia is a clinical diagnosis. So it's a patient that has cough, fever. So procalcitonin we've been using during COVID, but it's not always the best test. And then I agree with you, CBC, BMP, we definitely want to do that. EKG, so everything else is actually perfect. ABG, why do we want to get an ABG? Victor.
You say Victor or Richard?
Yes, I'm here.
I said Victor, but
I mean, this is a patient who's presenting with dyspnea with some focus in the lung. So I can't remember what her SpO2 was, but I guess an ABG would always be a good idea for dyspneic patients.
Yeah, I mean, it's always a good idea. She was not hypoxic, her
Okay.
SpO2 was 96%, which can be considered borderline, but definitely something that can give us some information if we're worried about dyspnea. And then, Eduardo, you're right, COVID, flu, these are all things, even though she's not really febrile, she doesn't have signs of infection, but definitely it's something that we might think of. Gomi is asking, why ABG versus VBG versus no gas? So I think no gas might be an option because she's not really hypoxic, and SpO2 is usually pretty fine unless we're thinking, other source of like CO intoxication. So we'll be fine not to get any gas. ABG versus VBG. So usually ABG tells us more information about the oxygen versus the VBG. You want to know if the patient has, hypercapnia. So that's why technically you would do an ABG. Then we get so many VBGs, usually just quicker, and ABG we need to go and do it ourselves. But that's probably like the reasoning there. Okay. So now that we have an idea of what we want to do, Anne, do you want to go back and tell us? I'm going to share back your presentation.
Okay, so as most of you said, so this is the initial labs that we got from her. So the CBC was remarkable only for a mild anemia. The CMP showed glucose 183, sodium 137, potassium 4.3, creatinine 1.49, BUN 26, MAC 1.9, calcium 8.5, ALT, AST normal, LDH 163, total protein 7.1, and albumin 3.2. BNP was slightly elevated, 223, and TROP was normal. Thyroid panel was also normal.
And now I'm curious to know, do you guys think these are helpful labs? Are they giving you any hint of what's going on? What are we thinking after that troponin? Anyone? Okay, so I think I can talk, but my point is these labs are not 100% helpful. They're not really telling us anything. We're ruling out anemia, but we really were not thinking about anemia as a cause of dyspnea. Her troponin is negative, but I don't think that tells us 100% that she does not have ACS or something going on. She might have a first negative troponin, so that's something we need to think about. If we have a high suspicion, we need to get second troponin, we need to get an EKG. And then the rest of the labs are pretty normal. I don't know what's the baseline creatinine, but it's unlikely that she has nephrotic syndrome from this labs. She has a good amount of troponin, pretty good amount of albumin to be an elderly female. Okay, so let's see what they did next. Okay, we have a chest X-ray, and we have Dr. Rothman with us. So does anyone want to try and read the chest X-ray? And Nadine, sorry, I didn't see the chat. I agree with you. Perfect. It's negative, but we should probably repeat it. Anyone wants to read the chest X-ray, so Dr. Rothman can also help us go through the chest X-ray. Otherwise, I'm just gonna pick someone, guys.
I can try.
Okay.
So it looks like good penetration. Looks like the rotation is normal. It doesn't look towards one side or the other. Looks like good inspiration. Maybe vascular congestion bilaterally, and then on the right side there's the angle is not clear. The left side the angle is clear. There's also like possibly a consolidation versus a fusion. I think that's all I got.
Okay. I don't know if Dr. Rothman wants to add anything. And
yeah, can I add something for the chest X-ray before Dr. Rothman? I think there is like, even though that we see like some maybe consolidation, I think there might be like atelectasis because there is shift of the heart to the right side. It seems like, even though like we don't have, I can see like some costophrenic angle still there, like that might be actually the diaphragm that's being pulled by some sort of atelectasis. I just wanted to add that.
Okay, and also we have, thank you so for your intervention. And also Sam is asking if the airway deviated when the trachea splits, if there's any deviation.
Julia, there's one more thing I want to add as well. The left aortic knob as well does not seem to be very prominent. And there's a dilation of what seems to be, I'm not sure, but the aorta seems like all over the place. So this is something as well.
Thank you. Thank you for adding that. Let's see what the expert thinks.
Yeah, no,
100%.
and I think those are all excellent points. You know, I agree. You know, the left lung looks grossly clear. You can really make out the costophrenic angle on the left side of diaphragmatic border. I agree there may be some shift of the heart towards the right side. I feel like the left lung in terms of aeration is a lot bigger than the right lung. So maybe there is some element of volume loss on the right. And then if you look, you know, usually with like a classic simple effusion, you know, it'll be very linear. You know, the patient's sitting upright, right? So the fluid, if it's simple, should be gravity dependent. So, you know, the top of where the ending of the effusion should be a nice linear line, and there is like a little bit of irregularity there. So, you know, I'm not sure. You know, I can't make out the diaphragmatic border here. And I think there's probably at least some fluid, but you know, maybe it's you know, a little bit more chronic in nature and associated with some atelectasis. So I'm sure we have some other tools that we can maybe try and help with our differential a little bit more.
Absolutely. So thank you so much. Guys, when you have this chest X-ray, do you stop there? Do you think we need more tests? What's your thinking? If that's your patient, you're the resident in the team, what do you think?
Bedside ultrasound, since Dr. Rothman is here.
Okay, that's cheating a little bit. So Tom is saying get the CT, Kruti is saying compare with prior chest X-ray. I think they're both great points, so we cannot stop there. CT, what other imaging can we get? And Nadim is asking, is a lateral view useful for the chest X-ray? I think it is, and again, Dr. Rothman might give his opinion, but I think it is because with the lateral chest X-ray, you're able to see if sometimes there's a mass, or if it's fluid, if it's dependent fluid or not. So that will definitely help you. Okay. I think before we go on, I just want to go with Anna's patient and see what they actually did. So they also did not start with the chest X-ray, and they got this CT. Anna, do you want to tell us what they found?
Yes, I want to go back a little bit to the chest X-ray. The official reading from radiology was like a subpulmonic large pleural effusion. Also, they said that there were some atelectasis component as well. So we did CT chest that it's shown next, and it showed like a large right-sided pleural effusion, no other significant lesions.
Okay. And then here they did EKG. I think for the sake of time, Anna, can you tell us?
Yes, it's just a normal sinus rhythm, no other abnormalities. Yeah,
absolutely. Okay. So here the team also got an echocardiogram, and if you want to tell us.
Yes. So the repeat TTE showed like a left ventricular ejection fraction of 65%, normal right ventricular wall motion, resting left ventricular filling pressures are probably normal, and compared to the prior TTE 1 year ago, there is no significant change. So this is the summary I had for you guys. So this is an elderly female with multiple comorbidities, including HFpEF and CKD, former smoker, admitted with acute and chronic dyspnea, and a unilateral right large pleural effusion. with no objective signs of infection, with subtle but not definitive signs of hypervolemia, heart failure, such as bilateral lower extremity edema and mild elevated BNP, but no GVD, hepatojugular reflux, scallops, etc. So what is the differential diagnosis for you at this point, and how would you approach a patient with a pleural effusion?
Yeah, just how, if you have a patient with this pleural effusion, we don't really know if that's new or old apparently. What do you guys think, and how in your mind would you approach a patient with pleural effusion? Okay, diagnostic tab, unilateral versus bilateral, okay. And Nadim, can you tell me more about unilateral versus bilateral?
I was just like thinking that because it's unilateral, our suspicion for something like a heart failure exacerbation goes down, and our suspicion for things like malignancy, infection, you know, empyema, stuff like that goes up. So
Absolutely. So definitely uni versus bilateral. That helps thinking about systemic process that can cause fluid overload versus a specific area in the lungs. And then Debbie and Martin are saying exudative versus transudative. That's also a very good point. And I guess then before we jump into that, would you guys tap this patient or no? Like, how do you decide who needs a tap? Are you guys calling POEM or? Okay.
Well, I was going to say it's got to be amenable to being tapped, so it's probably going to be based on size to an extent,
Okay.
and like where specifically it's located, I guess. But
Okay.
symptoms.
So definitely size, because if it's, Kevin was saying more than 1 centimeter, if it's less than 10 millimeters, it's not tappable at all. So definitely that makes sense. Symptoms, Juan, can you elaborate on that?
So she's coming in with dyspnea. So, but she's not hypoxic. But if she were hypoxic, I would definitely tap it.
Okay, so if you're thinking that her dyspnea is because of diffusion, that's definitely a criteria to remove, and that in that case becomes a therapeutic one. Then Daya is saying, do we know patients dry versus wet weight? I don't know, Anna, do we know that?
The weight?
Yeah, the dry versus the wet. Like if she had gained any.
No, she didn't gain any weight.
So we don't know, like after diuresis. Okay, that's fine. What other criteria do we need to think of to decide if we need to tap a patient with a pleural effusion? Alarm symptoms, what are those?
like weight loss.
Okay. Okay, so absolutely, if we have a specific suspicion. And I think in general, if we have a new pleural effusion, we need to tap it. Like we need to know what's going on. There are like some possible exceptions. Like if we know that the patient has CHF 100%, and she's coming with a fluid exacerbation, maybe bilateral pleural effusion, we think that's the cause. Maybe we can avoid a tap. But most of the other causes, especially for a unilateral large effusion, that we will need to find out more about it. And I don't know if Dr. Rothman, there's anything else that we need to think of when we decide if we need to tap an effusion.
No, yeah, I mean, I would basically just agree with that last comment that any new unexplained unilateral effusion should be investigated further, usually with a tap, unless there's like some, contraindications, like the patient's, for whatever reason, the size is too small or they're on anticoagulation or, but I think it should be investigated further.
Okay. And then once we tap, what do we look for? What are the labs that we have to look for? Someone had mentioned Light's criteria. How do we calculate that? We don't need to tell me the Light's criteria, even though for the boards, guys, you will need to know the Light's criteria, I'm telling you. But just, okay, LDH, protein serum. Perfect. So we need LDH and protein from both the serum and the pleura. So those are things that we always get. Okay. So we need to calculate the Lights criteria with LDH and protein. And then what else we usually get?
Cytology.
Yeah. What did you say? Sorry.
Cytology, maybe.
Cytology, definitely. Where else? It's the things that we most commonly send. Glucose, gram stain, perfect. Gram stain.
Also get an AFB stain for like tuberculosis.
Yeah, if we have a suspicion, definitely we can send. Oh, sorry. Okay. And then someone said cell count, and of course, then differential. Absolutely. Blood in tap, often suggestive cancer, that's totally true. So if it's bloody, we might have suspicion of that. And then gram stain with cultures. Okay, so I think you guys said all the most important things. And last one that I would add is pH, and then we'll see about that. But otherwise, there's more uncommon things like adenosine deaminase and BNP, pro-BNP, all this other stuff that we don't usually send unless we have specific suspicion, okay? So how do we tap it? What type of imaging can we use to kind of help us tap diffusion and also kind of identify some criteria of diffusion? We said CT, focus, perfect. Ultrasound guided, exactly. So I think Dr. Rothman can tell us a little bit more about that. And then we can continue for our case with our presentation.
Sorry, you want me to just talk about like the POCUS real fast, or?
We can, I don't know, we can go over the case if you want and then finish with focus later. That's as you prefer, if you think it's best.
Yeah, no, I think we can talk about it because obviously if we're like setting up, we want to, if we're trying to find like the safest pocket, right? Ideally, you want the patient to be able to sit up and essentially leaning forward, and you can look even like mid-scapular in the back region, or there's also something called the triangle of safety, which is along the mid-axillary space. And that tends to be the safest spot if we are going to tap. And then you want to, sort of just track it down when you're trying to find the size of the effusion. You want to always identify the diaphragm because that'll delineate what's, intrathoracic versus what's below the diaphragm or intraperitoneal. So, you usually want to see the diaphragm at the right of your screen, and then, some collapsed lung towards the left of the screen. And then you want to see how deep the effusion goes. That way, you know whether or not it's safe enough to tap.
Perfect. And usually how much fluid do you take? How do you decide if it's a diagnostic versus a therapeutic?
Yeah, so I would say, diagnostic, the most of the Thora kits come with a syringe that is either 10 cc's or 60 cc's. I think if we're going to send something like cytology along with all of the other pleural fluid studies, I'd probably take at least 60 cc's just for the diagnostic. And then the therapeutic would just be draining it, essentially dry. We don't like to go beyond, 1.5 to 1.6 liters because that, puts you at risk for some procedural complications such as, reperfusion, pulmonary edema. But definitely since she's symptomatic, I'd probably just, if we're going in there, we might as well just drain it completely as long as she can tolerate it.
Okay, thank you so much. Okay, so now we're tapping our patient. We decided that we're tapping our patient and we're looking at the Lights criteria. So they will tell us if it's transudative versus exudative, right? One point that I want to make is that the Lights criteria are extremely sensitive. They're like 98% sensitive. So they will catch any exudative effusion, but that will mean that some of the transudative effusion will be labeled wrongly as an exudative transfusion, okay, effusion. So let's think about that when we calculate the Lights criteria. And then I think one way that at least I think about transudative versus exudative is the mechanism. So transudative is more passive. So there's like passage of leakage of fluid, and it can be because of an increase of the hydrostatic pressure or for a decrease of the oncotic pressure. While exudative is more like an active system, there's like inflammation. So cells are actually moving in the pleura, cells and protein, a lot of junk is going in the pleura. And for me, at least, it's easy to think about infection versus non-infection as a possible etiology of the exudative effusion. So can you guys tell me some causes of transudative effusion either because of an increase of the pressure or a decrease of the oncotic pressure. Heart failure, low albumin, okay, heart, liver, renal, perfect. So heart will be usually increase of the pressure, while in case of hypoalbuminemia or hypoproteinemia, so nephrotic syndrome liver, that's gonna be more here. It's gonna be more because of a decrease of the oncotic pressure. And then we have to also think about situations like constrictive pericarditis that can cause an increase of the diastolic pressure, or trapped lung. So when there's trapped lung, the lung cannot really expand, and that causes a negative pressure in the pleura that will take fluids in. So that's gonna go here in the diastolic pressure section. And then exudative, I think that's pretty obvious. So infection, any type of infection, right? Bacterial infection, fungal, we were saying TB, anything. And what about non-infectious causes? I think we mentioned some of those already. Exactly, cancer, what else? There's like tons of it. Autoimmune, absolutely. Yes, rheumatoid, SLE, yeah, this can all cause that. Other things, for example, after a CABG, you can have an exudative pleural effusion, or what's called PCIS, post-cardiac injury syndrome, and then other things like PE, chylothorax, absolutely. So a lot of things can cause an exudative effusion. At this point, I just want to add a couple of things. Let's say that we have an infectious exudative effusion. What are we looking for and why? There are some criteria that are very important that will kind of change the approach to the effusion. Let's say we have a patient with a pneumonia and she has also pleural effusion. What are we looking for when we tap the patient? Empyema needs drainage, and how do we know if it's an empyema? Okay, and complicated, perfect. So we have to kind of define empyema and what is complicated versus uncomplicated. Okay, glucose pH, can you guys tell me a little bit more details about that? What pH tells me that's a complicated pulmonary effusion?
I think if it's acidic, I don't know if more acidic is more likely to be when they have like an empyema and a bacterial infection.
Absolutely. So usually acidic pH, so minus 7.2 or 7.3, exactly 7.2, perfect, Ruti. And then glucose also, if it's a low glucose, usually less than 60, that's also a criteria for complicated pulmonary effusion. What else? So we said earlier that we look for gram stain and for culture. So if any of these are positive, that's also a complicated effusion, because that means that the effusion is not sterile. There's something going in the flora, which is bacteria or any type of pathogen. So that's not sterile anymore. And then the other thing, empyema. So if it's pus, so if you see pus when you're draining, so all these criteria means that the patient needs a full drainage of the effusion itself. Okay, so now let's go back to our case. I'm going to share back presentation. Okay, Anne.
Okay, we can go next. So as you already discussed, so whenever we have a patient with a pleural effusion, there is a couple of questions that we need to ask ourselves. Number one, is the pleural effusion large and is causing a significant increase in work of breathing? Then if the answer is yes, you need to do like an urgent thoracentesis for therapeutic purposes. Then question number two, so is the pretest probability of an exudate sufficiently low, or on the contrary, is the pretest probability of a transudate sufficiently high? Then let's say, as you mentioned before, a patient with pretty clear heart failure and bilateral pleural effusion, or decompensated cirrhosis and not sign of infection, then the answer is that you may skip thoracentesis in this patient and just treat the underlying condition and see what happened. All other patients, however, will require a thoracentesis with pleural fluid analysis for diagnostic purposes. So this is like a framework for pleural effusion. So in the middle, there's the LICE criteria, as you already discussed. So if none of the criteria are present, then we are seeing like a transudative effusion. And the most common causes for this are CHF, liver disease, ESRD, nephrotic syndrome, and pulmonary embolism. There are other rare causes like brachycephalic occlusion, SBC syndrome, trapped lung, and decreased protein fluid, like very rare cases with urinothorax or central line misplaced. On the other side, with one or more LICE criteria present, then we're talking about an exudative effusion. We can divide the etiology in primary and secondary. The primaries are the most common ones are infection, cancer, autoimmune, drugs, and again, pulmonary embolism. Rare causes are chylothorax and asbestos. Also, the secondary etiologies that we may see unilateral would be like on the right side, effusion secondary to Meigs syndrome. I don't know if you guys remember what Meigs syndrome is, but this is like a triad of benign ovarian tumor plus ascites plus pleural effusion. Also, we can see it in endometriosis, and on the left side, we can see it secondary to pancreatitis and secondary to esophageal rupture. We can go next. So if for sure we are in the presence of an exudate according to the LICE criteria, then we need to ask these questions. So is the pleural space infected? Are we seeing or suspecting like an empyema or a complicated parapneumonic effusion? If the answer is yes, then we need to place a chest tube for the management of the empyema. Second question, does the patient have cancer? Cytology must be obtained. The sensitivity for the first cytology, it's like around 60%. With the second cytology, this sensitivity will increase like between 5 and 15% more. So if no obvious cause for pleural effusion after 2 negative cytologies, then the next step will be a pleural biopsy. And also getting imaging post-thoracentesis may also help, because once we drain the fluid, we may be able to see any occult tumor or lesion. And also a pleural effusion, which is lymphocytic predominant, is due to tuberculosis until proven otherwise. So this is the results from the pleural fluid of our patients. So it showed WBC 353, lymphocytes 71%, neutrophils 12%, and macrophages 13%. Glucose was 155, protein 4.7, albumin 1.4, and LDH 95. Triglycerides 45, and cytology was benign. Also, bacterial, fungal, and AFB cultures were negative.
We want to calculate the LICE criteria. Do you remember, Anna, the protein?
The protein was 7.1. Serum protein was 7.1.
Okay. So does anyone want to tell me if we do 4.7 divided by 7.1? So it's 0.66. So technically, LICE criteria are positive. So technically, this is a exudative effusion. So what will be your, like, yeah, 0.66. So what are we thinking at this point? Like, I'm confused a little bit. What's in our differential now? So we have these patients, just no signs of infection or anything that we might think that she has a pneumonic effusion or anything like that, but she has a exudative effusion. What would you guys do next, and what are you thinking? Okay. So, I mean, for me, that would be a little confusing in terms of I don't see any specific hint. Okay, so throw biopsy, autoimmune, ANA, I will get autoimmune labs. Okay. Repeat cytology. Okay, so definitely the cytology, as we said, it's not really very sensitive. So if she has some risk factors, she was a smoker, she's elderly, even though she's not really losing weight, but definitely we might think that this is a malignant effusion. Autoimmune, yeah, I think also there's lymphocytes and we don't really know what's going on right now. And do imaging again. I'm just curious to know Dr. Rodman's point of view, if you have this patient and these labs, if there's anything that we should do or think of.
Yeah, so I think, yeah, a lymph predominant exudate, right? So I think, you know, an elderly woman who's presenting for the first time with shortness of breath and like no other real systemic like infection like symptoms, I think it is probably, I'm so concerned for malignancy, even though the first cytology is negative. So I'd probably, you know, reassess if there's fluid reaccumulation, maybe getting the imaging, repeat CT imaging post thoracentesis. The other thing I was wondering is if a fluid ADA was sent. That's sometimes helpful in diagnosing patients if we're worried about like TB pleurisy. If it's elevated, it would be suggestive of a tuberculous effusion. So that would be the only other thing potentially to send as well with the initial fluid studies.
Anna, was it sent?
It was sent and it was normal.
Okay.
Yes.
What was the team thinking, Anna? I'm just curious at this point.
Yeah, so it was very confusing for us as well. So we consider at some point to pursue like pleural biopsy, but this wasn't, you know, in line with the course of cares for this patient. So also, can we go to the next slides?
Absolutely.
Yeah, so we repeated multiple times like the cytology and it was always benign. So the cultures also were negative. Can we go next?
Okay. So before we go there, so Krudi is asking if the APB cultures are sensitive. I'm actually not, I don't think they're very sensitive or not. I would not know the amount of the number.
So I would say, yeah. And actually I would say in general, the cultures, when you take it, it depends on how it's sent. Usually the sensitivity is pretty low unless it's sent in like almost like blood culture bottles, because it needs, you know, it has better results with, you know, the media necessary for it to grow. The other thing I would say is like, if we are pursuing like pleural biopsy, I think, you know, we used to do sort of like Abrams needle biopsies at the bedside. Now it's probably better to do, you know, call interventional pulmonology and do maybe pleuroscopy with pleural biopsy. That way you can sort of actually go in with a camera and visualize areas of irregularity and take multiple biopsies to improve the yield.
Okay, and there's two more questions, and if you can help me with that. So Sammy is asking if that amount is a lot of lymphocytes, the 73% on the, I think it was 350 white blood cells. Is that usually like a very large?
I mean, it's definitely abnormal. You know, obviously I've seen like 90+%, but I think if it's a majority, that's abnormal.
Okay, and then another question, if it's their tuberculosis PCR, I'm not sure actually, I don't know.
I don't know, yeah.
No.
If there is that, we don't generally send it here, yeah.
And then Tom is definitely bringing up a very great point. He's saying probably not useful, but were diuretics used during hospital course, I think that can sometimes cause a transudative effusion to look exudative. That's
correct.
Great point. And I think Anna here.
Yes, correct. That's an excellent point. So if she were like a different patient with no history of a CHF, then yes, we'll go with the lights criteria 100%. This is an exudate. But since she has the history of the heart failure and she's been diuresed chronically, then we may have seen like the possibility of a pseudo exudate, because the light criteria are intentionally very sensitive to detect exudative effusion, but false positive are possible, particularly in this kind of patients. So the next step, if we have any doubts, would be to calculate the serum infusion albumin gradient to identify if it's really like a transudate or an exudate. This is very similar, guys, to the SAC that we calculate for patients with ascites. So in this case, the cutoff will be like 1.2 grams per liter. So we did the calculation, and in this patient, it was 1.8. So below 1.2 will be an exudate, and above 1.2 will be transudate. So in this case, actually a pseudo exudate. So we concluded that the final diagnosis for this patient was a pseudoexudative pleural effusion in the setting of chronic heart failure. So this is a very summarized illness script. Pleural effusion, as you know, is more like a syndromic diagnosis. But I think this is the key things that you may remember whenever you're thinking about it. So first of all, the definition, which we already know, the diagnosis that can be done with conventional chest X-ray, ultrasound, CT, and MRI. The causes, we need to go by the lights criteria, as we already discussed. And the treatment would depend on what is the underlying cause for the pleural effusion. Of course, drainage for symptomatic patients, and as last resources, pleurodesis and indwelling pleural catheter.
I'm actually curious, was the team convinced that that was the reason that she had the effusion, or they weren't sure?
Actually, that was the final consensus with the pulmonology team as well. I think if the overall picture were different, maybe they will pursue like a biopsy, a pleural biopsy at the end. But since this wasn't, in line with the goals of care for this 86-year-old lady, I think we just concluded the case as this.
Thank you, Anna.
Thank you all.
I don't know, Dr. Rothman, if you have any other points, I don't know about focus or anything else regarding this case.
No, I mean, it's interesting, I think because the rest of the lung parenchyma looked okay, the left side looked completely normal. So to have just like an isolated large right-sided pleural effusion that we're attributing to diastolic heart failure, I don't know. Yeah, it's interesting.
Yeah, and a question I had, like, if we do the chest X-ray, would the next step be an ultrasound, and would that be enough instead of doing a CT, or you would still get a CT and the focus to kind of look at the effusion and then tap the effusion?
Yeah, I mean, I think of the imaging options, probably a chest X-ray is probably the least sensitive, so I think, you can pick up, obviously vascular congestion and effusions a little bit more readily on ultrasound. And then I think the CT would have been good just to, see if now that the fusion has been taken care of, is there any other like hidden lesions that we maybe didn't see before? And I'm guessing there was no lymphadenopathy on the initial CT. It was really just the isolated effusion.
Yeah, we didn't see anything else.
Okay. Does anyone have any questions or comments?
Would you consider bronchoscopy for this patient to determine if there's a malignancy that we're not seeing?
So I think I would only do a bronch if we saw something that was overtly obvious on the like a CT, like meaning if we saw like a mass or even like a lymph node enlargement that we could potentially biopsy. Otherwise, we only just looking at the airways without any clear evidence, I suspect we wouldn't find anything.
Okay. Oh, and Tom is asking, would a PET scan be useful in a patient with a different goals of care? Interesting.
Yeah, I mean, I think, I think it would be hard, I think if the CT is completely normal appearing, to justify getting a PET, and then, even then, it would have to, I think any type of investigation that you potentially find abnormal on the PET would need some type of procedure to biopsy it. So it may not be worth it.
Yeah, okay. Also because of that, they will do outpatient, but definitely maybe the patient will need more workup. Okay, guys, if you don't have any other questions, we will thank you, Anna and Dr. Rothman, for joining us today.